Great. So hello, everyone. Welcome to Caring and Living in Neighbors side event at the Science Summit at the 79th United Nations General Assembly. My name is Katie Blomquist. I am a Master's of Public Health student at Lehigh University, a UN Youth Representative for CLAN, and the Mates for Kids Project Officer. I'll be co-hosting this event with Kate Armstrong, who is the president and co-founder of CLAN. So just housekeeping, please make sure that you're muted if you're dialing in virtually. And this event will be recorded and posted with a report soon on the CLAN and Mates for Kids websites. We would like to acknowledge the lands that everyone is dialing in from virtually. We invite you to post the traditional lands that you're on in the chat now. From Lehigh University in Bethlehem, Pennsylvania of the United States, I acknowledge I'm presenting from the lands of the Lenape people, and I pay respects to elders past, present, and emerging. As CLAN is based in Australia, we acknowledge the traditional owners of country throughout Australia and recognize their continuing connection to land, waters, and community. We pay our respects to First Nations peoples, international, and their cultures and elders past, present, and future. So this event is in partnership with the Lehigh University United Nations Youth Rep Program. The Lehigh University Youth Rep Program started in 2008, where high-achieving Lehigh University students are matched with UN-accredited NGOs. CLAN is one of the 9 NGOs and one of Lehigh's strongest partners. CLAN currently has 2 UN youth reps, Nikki Pasterchick and I, who advocate for CLAN at United Nations events such as this one. This program allows youth to have a voice in global matters and, in our case, treatment for children with non-communicable diseases. The Science Summit during the United Nations General Assembly is a premier global event that unites thought leaders, scientists, and policymakers to address the most pressing scientific and technological challenges of our time. The key focus areas include climate action, One Health, biodiversity, food systems, artificial intelligence, science, philanthropy, quality education, affordable and clean energy, indigenous knowledge, and more. The Science Summit aims to bridge the gap between science and policy, ensuring that scientific insights and advancements inform the creation and implementation of effective, sustainable, and inclusive global policies. The Science Summit objectives are to present key scientific initiatives, foster collaboration, promote inclusive science, bring together key stakeholders, develop scientific capacity, and enhance global cooperation in science to address worldwide challenges. These objectives align with CLAN's mission to optimize health outcomes for children and their families, coping with chronic conditions in resource-poor settings. Universal access to newborn screening is essential to ensuring that children with chronic health conditions that can be diagnosed at birth can enjoy a quality of life comparable to their peers in wealthier nations. The 2024 Science Summit is particularly significant as it coincides with the UN Summit of the Future, focusing on envisioning and planning for the post-SDG era. As the target date for the SDGs approaches, identifying gaps and exploring innovative solutions to ensure sustained advancement beyond 2030 is vital. The newborn screening programs ideally support comprehensive approaches to the early diagnosis of congenital anomalies and can include physical examination of the body, hearing and vision checks, pulse oximetry, and heel prick blood spot testing. For those unfamiliar with the specifics of newborn blood spot screening, it is a heel prick method where blood samples are taken from a newborn and tested for multiple genetic, metabolic, endocrine, and other long-term conditions. It's pivotal for children with chronic conditions that can be diagnosed early so that treatment can be started within a few days of birth to prevent morbidity and mortality. So now I'd like to introduce you to CLAN. CLAN, short for Caring and Living as Neighbours, is an Australian non-governmental organization founded in 2004 by Dr. Kate Armstrong. CLAN is committed to equity for children living with chronic health conditions in resource-poor settings. CLAN's strategic framework for action focuses on multi-sectoral action on 5 pillars. Pillar 1 is affordable access to medication and equipment. Pillar 2 is education of the individuals, families, communities, health professionals, policymakers, and the international community. Pillar 3 is the optimization of medical management, including primary, secondary, and tertiary prevention with a biopsychosocial focus. Pillar 4 is the encouragement of family support networks. And the final 5th pillar is reducing the financial burdens on families that result in poverty, helping people to become financially independent so they can provide the necessary health care for their children long term. CLAN is focused on promoting equitable access to newborn screening services for all children in the world, as it supports the early diagnosis and treatment of many chronic conditions of childhood that are associated with preventable morbidity and mortality. Special efforts are going to be needed to reach babies from resource-poor settings and families. Now I'd like to introduce Dr. Kate Armstrong, founder of CLAN and co-chair of the Mates for Kids movement.
Thanks very much, Katie. Really appreciate that. And thanks to the fantastic speakers we have joining us today. Next slide. Thanks, Katie. I'm just briefly going to introduce Mates for Kids, which is a global movement of individuals and organisations committed to reducing the preventable mortality associated with congenital adrenal hyperplasia, which is one particular childhood NCD, non-communicable disease, chronic health condition, reduce it by 30% by 2030. We acknowledge that these efforts will contribute to member states' commitment to delivering on the SDGs, the UN's Sustainable Development Goals by 2030, particularly SDGs 3.2.1, 3.2.2 and 3.4. We shared our first briefing paper in February 2022, and it's a privilege to share another briefing paper today, and I'll speak about that in a second. But just initially wanted to talk, next slide, thanks, Katie, on how we're planning to reduce preventable mortality associated with CAH. And it's 3 main things. It's improving access to essential medicines and equipment. And Prof. Aman will be talking to us later about the work of the International Paediatric Association, and we have a working group there that's really committed to driving change on that, but also members of the Mates for Kids community of practice really work hard to find innovative solutions. Strengthening CAH communities, and we'll be talking a bit more about some grants that are being given to support that, and finally scaling newborn screening. Just next slide, thanks, Katie. So as I mentioned, with affordable access to medicine and equipment, and that really does include newborn screening equipment as well, but improving essential medicines to equipment really is a basic human right. Children have a right to life, and conditions like CAH and diabetes is another one where children need medicines to stay alive. We really need to take some dramatic action to make sure that children, especially in low-income countries, can afford the medicines that they need to survive. Next slide, thanks, Katie. We mentioned community development. Katie, thanks for speaking about CLAN's strategic framework for action. It's a holistic, rights-based community development approach that really involves a whole range of stakeholders in driving long-term change to improve quality of life for children. And I'd just like to call out the team in Colombia who have been held their first CAH Club meeting just this year and are really seeing some exciting changes for the CAH community of Colombia as a result of the work that so many different stakeholders are doing. Next slide, thanks, Katie. Newborn screening, it was encouraging that WHO passed a resolution, member states passed a resolution at the World Health Assembly in Geneva this year, acknowledging the role that newborn screening will need to play in achieving the SDGs. It's worth noting that this month is Newborn Screening Awareness Month, so it's fantastic that some of our talks today are focusing on newborn screening. Really timely and coincidental in September, the month of newborn screening awareness. Next slide, thanks, Katie. But last, I just wanted to speak a little bit about how we do it, and this model here on the left-hand side speaks to the yellow circle is the Mates for Kids community of practice, and we always keep the CAH community at the centre, and we're grateful to the international CAH community who help us with that, but we bring together as many different stakeholders as we can, and we work collaboratively on those three objectives: access to medicines, community development, and newborn screening. We bring together stakeholders in from the 6 WHO regions of the world. We have to, with time zones, bring together the Americas, Africa, and Europe, and then at some meetings, and then the next meetings, the Eastern Mediterranean, Southeast Asian, and Western Pacific region. But we come together and share ideas. We also leverage events, and on the Mates for Kids website, and Katie, you might just put the Mates for Kids website address in the link if you could in the chat. But we have a lot of different reports of we've spoken at the Commission on the Status of Women, Small Island Developing States meetings, the World Health Assembly, a whole range of different meetings. We've come together to talk about these really important issues and what we can do together to reduce preventable childhood NCD mortality. We're grateful to WHO for letting us use the Knowledge Action platform as well as to help us all come together and communicate. But lastly, last slide, thanks there, Katie. I'd just like to talk about this paper that we're very proud to be launching today. And again, I'm just putting a link in the chat to the paper that's available on the Mates for Kids website. It's also available on WHO CAP, the Knowledge Action Portal. And it really outlines Mates for Kids' community-centred collaborative health system strengthening approach to reducing the preventable mortality associated with CAH by 30% by 2030. We acknowledge this Health Systems Plus framework that's been developed by the team at St Jude's, and they developed it initially for childhood cancer, and we're adapting it for CAH. It's really about centering the community of children living with NCDs, and then collectively driving action around the WHO's 6 building blocks for health systems strengthening. So that's community and stakeholder engagement, governance and financing, medicines, equipment and technologies, health service delivery, health workforce, and information systems. So this briefing paper really outlines some of the actions that different members of the Mates for Kids community are taking to drive change and reduce preventable mortality associated with CAH. So we hope that you might find that useful. That's all from me, Katie. Thank you. Handing it back to you. Thank you.
Thank you, Kate. So next, I'd like to introduce Professor Aman Palungan. Aman is a professor in pediatrics, a senior consultant in pediatric endocrinology, and the current executive director of the International Pediatric Association. He has served as the past president of the Asia Pacific Pediatric Association, the Indonesian Pediatric Society, and the Asia Pacific Pediatric Endocrine Society.
Okay, thanks, Katie, and good morning all, and good evening from Indonesia. I'd like to share what's, well, we'll see, it's not really a success story, but we are actually doing something growing about newborn screening. Next slide, please. Next slide, please. This is one picture from National Geographic. It's the Indian from Mexico. It's about from 780 AD. The tribes of Mayan Mural. They have been doing history of that spot. You can see the Mayan woman would let their drops of blood fall on paper that will be burned to conjure up the god. So the idea of newborn screening, I think, has been 1,000 years ago. We can see it from, this is the picture from National Geographic. Next slide, please. So yeah, talking about newborn screening, we know this is part of the SDG. So especially point 3.2, the end of all preventable deaths under 5 years of age. Let's say a lot of disease, including like CAH, something like that, and also reduce mortality from non-communicable disease and promote mental health. This is part of the, of course, to reduce 1/3 of the mortality from non-communicable disease. So next year we are 5 years to SDG. So a lot of onward, I think, from all countries all over the world. Next. Newborn screening is a system. Component education, screening, diagnosis, management, follow-up, and evaluation, integrated and implemented within the public health program. So this is a system, and this is a public health program, considering economy, political, social, and cultural aspect. Recommended uniform screening panel, you can see it here, CAH, congenital hypothyroidism, CH, congenital heart disease, and hearing loss, beta thalassemia, sickle cell disease. Yeah, you were mentioning before, and metabolic disease, a lot of metabolic disease. Next. So this is Indonesia. We have 17,000 islands. You can see it here, the size of Indonesia. And right now we have 4.8 million newborn every single year. So every year we have amount of baby similar to population in Singapore. Every single year. So you can see the total area of Indonesia, and we have right now 38 provinces. So it's a really big, islands, and also the biggest archipelago in the world. And right now the total population 281 million people into 2024, and 39.2% of the parents still refuse screening for the newborn. This is still our challenge. Next. So this is the history of our newborn screening, start from 1999, but a long way to go after 20 years. And you can see it here. We have the relaunch of newborn screening. We have we have 8 Ministers of Health already from 1999 until now. So we start right now increasing it, so the Minister of Health right now released a new decree in 2023. So the coverage before, less than 2%. So we can see what's the growing now. See, next slide, please. Next. So this is part of our data, our paper to tell our Minister of Health now. Let's say this is our CH patient, 96%, they have developmental delay, and 72% intellectual disability. And most of our CH patients without screening, they had very low full scale of IQ, mostly below 70. Next. And we did some pilot study in Indonesia. It's really surprised that for CH, we have 1 out of 1,200. And for CAH, we have 2 out of almost 1,200. So we don't know the real situation actually in Indonesia if we don't do that, because so many tribes, we have more than 100 tribes in Indonesia. So probably our result would be different compared to any other part of the world. Next. So this is after the release of the decree in 2023. You can see, since before less than 2% is increasing. Before, for 1 year, less than 200,000 baby screen. And you can see this here, start from June and July, it increasing a month, from almost 100,000, and then more than 200,000 a month we screen in 2023. Next. And in 2023, 28% of population screened, so almost 1.3 million. And by July 2024, we already screened 1.3 million. So about almost 30%. So we aim until the end of this year, we will screen at least 50% of the population of Indonesia. No, not 50% of the population, 50% of the baby out of 4.6 million newborn. Next. Next. You can see it, how the coverage in 2023. Next. And this is what we're doing in 2024. Still, there is up and down of distribution of the paper, something like that, from the local Minister of Health. Still a problem, and also the recalling, because the archipelago. Well, of course, there is no excuse for this, but still, we still have a lot of to do with the training, the staff, and also the system delivery and sending the paper and everything is still a problem right now. Next. And this year, we start doing pilot project in Java for CAH and D6PD. And until July, we have started, I think, in May or April, something like that. So we have been doing it for 3 months for G6PD, for CAH, for congenital heart disease, and all of hearing problem. So we have been collecting almost 70,000 samples in Java, and out of this, I think is you can see it here. The positive is quite high, from West Java, Central Java. So 9 out of the 60,000. So our positivity rate, about 1 in less than 10,000. This is only for the pilot project here in Java. Next. So the challenge is the birth screening now. Next. Next. This is, we publish it also, the challenge about what's the problem in Indonesia. Next. Yeah, the geographic, demography, family refusal, lack of awareness, early discharge of the newborn. But we already overcome this with the reimbursement for the package for the delivery. So some of the newborn before, they live before 24 hours. Right now, if the primary health care or the hospital, they don't do newborn screening, so they have to leave after 24 hours. Otherwise, the government would not reimburse the cost for the delivery and the baby for the newborn baby. So they have to do it, after 24 hours, right? Insufficient training, this is still a problem. Resource constraint, lack infrastructure capacity, ethical dilemma, data management of coordination. So we still do it manually, and I hope we will do it this year with the one system, one health system, with the application and everything. Yeah, we hope, fingers crossed. Follow-up and treatment challenge, still a problem. Next. So the geographic demography, I've telling before, 17,000 islands still a problem, for geographic and family refusal, early discharge. But we overcome this with the reimbursement package of the delivery. Next. Next. So, insufficient training, resource constraint. We already have 11 labs in 2023, and right now we added for 14 labs. And in 2025, we will edit the lab for 38 province. It would be 29 labs. We don't know whether this is a good solution or not, but since the geographic still a problem, so we hope that to add more lab, it would be easy, for recalling and also doing sending the sample and follow-up treatment. Effective follow-up, we have to do it, and challenge data collection, still a problem. Next. Yeah, so our approach here establish the urgency, ensure the availability of the access, and also we make the company locally to produce hydrocortisone, levothyroxine, fluorocortisone, and involvement clinician, and together with Minister of Health, national training healthcare professional. Tomorrow I'm going to Manado to give a lecture also. Manado is another island in a Celebes Island, Sulawesi Island, close to Philippines. So tomorrow I will talk about newborn screening also with the Society for the Clinical Chemistry. National campaign to increase awareness, and this month is newborn screening awareness month. We will release a lot of flyers and also poster at the primary healthcare this month. Next. So for doing this, we have to do a lot of monitoring and evaluation, and I have to do it myself. Traveling to Surabaya, to a lot of lab to see if there is any problem with, at the beginning, because at the beginning, they are not used to have, a lot of sample, like, 20,000 sample, 30,000 sample in a week. So they have to increase also the manpower. Yeah. We are doing a lot just in 1 or 2 years, I think. Yeah, a lot of, error also at the beginning. Next. So I just got back from Kathmandu. We released Kathmandu declaration. That's one of the declaration that we need to increase the coverage, for all the country. We have not reached 50% to increase it at least to 50% or more. Next. And this is the participant from Kathmandu, from the Asia Pacific country. And our Minister of Health also joining, but by Zoom also. Next. So the plan for 2024 to increase coverage, our target coverage 80,000 baby in a week. More lab to overcome, so 14 lab now and 29 lab in 2025, and 2x screening for CAH for the whole nation. This is PDC, congenital heart disease, and all of the hearing. Next. So our priority newborn screening, as it gives opportunity to everybody with commitment and harmonized collaboration with the stakeholder, and overcoming technical barrier, and increasing awareness for mothers and family to concern for screening. Next. Yeah, let's strive to ensure all the newborn are screened. Next. This is the sample of our patient. The boy who was newborn screened and gave treatment for levothyroxine start from 1 week old. Right now, his IQ is 127, and he wants to become a pediatrician, he told me. And the other one was not screened, just unlucky, and just diagnosis when she was 10 years old. And right now, her IQ is 50-something. And she just graduated from the school, special school. And right now, she couldn't do anything. She just stay at home watching TV. Okay. Thank you, everyone. Over to you, Katie.
Thank you so much. So now Professor Aman is actually going to be presenting for Naveen Thakur. He is also from the International Pediatric Association. He's the director of Deep Children's Hospital and Research Center in India and president of the International Pediatric Association. But again, Aman will be presenting on his behalf.
Okay, thank you.
Mm-hmm.
Oh, Okay. Yeah, I will share our president slide about what's the role of pediatrician in driving change. Yeah. And also our invitation to IPA Congress 2025 next year. Next. So the IPA is the organization, is 114 years old. I think it's quite old. Global organization representing over 1 million pediatricians, saving life, improving the health of more than 1 billion children. IPA represents pediatricians from over 150 countries in over 174 member society. Next. So the vision is every child will be accorded the right to the highest available standard of health and the opportunity to grow, develop, fulfill to his or her human potential. The IPA will serve as an unceased voice for children, health, development, and potential through advocacy, education, and action. The IPA mission, our mission is pediatrician, working with other partners. This is what we are doing right now, working collaboration with PLAN, with UN, with WHO. So we'll be leader in promoting physical, mental, and social health for all children, and in realizing highest standard of health of newborn, children, and adolescents in all countries of the world. The IPA will work with professional associations and all other willing to add their strength to advocacy, education, and programming on behalf of the children. Next. So we have a strategic priority. Number 1 for children, and number 2 for pediatric workforce, and number 3 for pediatric society, and number 4 for partnership, collaborate with other health professional association and partner organization working for children health and well-being all over the world. And number 5 is for communication. So we have to enhance, effective communication with members, pediatric society, pediatrician, and other stakeholders. And number 6 is for leadership and governance, promote equity, diversity, and inclusion in IPA leadership, and achieve excellence in government and operation. Next. So the program area, we have program area and working group. So the program area is every mother for newborn, immunization, infectious disease, breastfeeding and nutrition, NCD and mental health, adolescent health, and education and pediatric workforce, early childhood development, and children in humanitarian setting and social pediatric. Next. And also climate change. Next. Yeah, beside program area, we have also a program area working for working group, polio, tuberculosis, food safety, childhood cancer, sickle cell disease, primary care pediatrician, antimicrobial resistant, IMR, school age, measles, rubella, essential medicine. This is newborn screening, access to medicine, access to care, also part of the essential medicine. Under 5, young pediatrician, children and disability, quality improvement, and patient safety. Next. We have a lot of webinar. We had about autism already, helping the child with diabetes, get education, coping in school, and also children are not a little that the transfusion practice in pediatric cancer. Next. So far, until August, from January, we have been conducting 33 webinars with over 9,000 registration on the webinar module. The webinar are conducted by over 10 program area and 12 working group in IPA. IPA program area on respectful care for every mother and newborn plan to conduct a webinar series. IPA webinar series raised toward achieving SDG goals, and the main aims is the webinar series entitled Race Toward Achieving SDG Goals, IPA has been conducting this webinar series since January 2024. Next. So this is part of the webinar about the newborn webinar series. We have a series. It's been doing it since January 2024. Next. So the IPA neonatal represent IPA member society has nominated 57 neonatal representatives who would be working with the committee to enhance maternal and newborn health outcome. So the clinical priorities, we have 8 clinical priorities. And for education administration, we have 7, including kangaroo mother care and standard education material, and of course, breastfeeding. Next. So the member society involved, a lot of society involved, let's say like Royal College and also Nigerian Society, Indonesian Pediatric Society, all the society, more than 150 society, more than 170 society. Next. So the IPA project, we have some project also for the immunization priority. And right now, we have the project with the Pediatric Association of Nigeria Fund and also Indonesian Pediatric Society. So in Nigeria, we train 200 participants, and in Indonesia, we train 66 participants through the national. Next. So this is the one from Nigeria. Nafin was there. Next. The regional workshop in Nigeria. Next. And this is from Indonesia. The workshop also opened by our Minister of Health. Next. The activities conducted immunization in Indonesia and Nigeria. Next. So IPA GSK vaccination, we have been also fee-to-fee workshop organized by the IPA to a country in Africa and Asia, and introduction to achieve higher vaccination coverage to reach zero dose children. Next. So this is the third IPA GSK workshop in Abidjan, December 2023 in Ivory Coast. Next. IPA Vaccine Trust project, we released also a publication for this. Next. Our partnership, we have a lot of partnership with ICN, WHO, PMNCH, Vigo, UNICEF, ICM, and COIN. Next. And some other project with CIOP, Global Affinity for Pediatrician Childhood Cancer, Care and Cure, Quality Improvement and Course, and IPA Vaccinology course, IPA course on Artificial Intelligence, that we have so far conducted 25 webinars for this. Next. And position papers and publication, we do it also. Next. So we invite you to our Congress in New Mexico next year, 8 to 11 May 2025. Okay, thank you. Over to you, Kathy.
Thank you so much again. So next, I would like to introduce the Sickle Ed team from Lehigh University. They are a team of undergrad undergraduate working to address the lack of disease understanding and diagnostic capability in sub-Saharan Africa. Lauren Jones, Nicole Hirsch, Adelaide Ogden, and Amelie Fry are Global Social Impact Fellows on the Sickle Ed team, working to create a point-of-care diagnostic service for sickle cell disease.
Awesome. Thank you, Katie. So hi, everyone. I'm Lauren Jones. I'm a member of the Sickle Ed team, and we're an undergraduate team, as she mentioned, from Lehigh University, working to create a point-of-care diagnostic device for sickle cell disease. Next slide, please. So for a little bit more about us, I'd like to go through the slogan. So the beginning says, from diagnosis to action. Our team believes that the solution to reduce the burden of sickle cell disease goes beyond just diagnosis. And to see real action occur, diagnosis must be coupled with an increase in treatment and expanded advocacy efforts. As for the second part of the slogan on the screen, we are primarily working right now in Sierra Leone due to our current connections. However, as we know, this is an issue across the region of sub-Saharan Africa, and we hope to expand our project as it becomes more developed. Next slide, please. So Katie introduced some of the students on our team, but to introduce myself a little bit more, I'm Lauren Jones. I've been working on this project for 3 years now. I'm a senior in college, and I'm majoring in population health with a minor in biology. If my other teammates could also introduce themselves quickly.
Hi, I'm Nicole Hirsch. I'm a junior and I'm pursuing an integrated degree in mechanical engineering and product design.
Hi, I'm Adelaide Ogden. I'm majoring in bioengineering and minoring in population health.
Hi, my name is Amelie Fry. I'm a sophomore and I'm pursuing an integrated degree in bioengineering and philosophy.
Awesome. We are also joined by 6 other students who aren't here today, but they're still hard at work on our project from also all varying different backgrounds and ages. And then we are also joined by our faculty advisor, Dr. Xuanhong Cheng. Next slide, please. Before we get more into what our team actually does, I'd like to take some time to acknowledge our partners, both in the United States and also abroad in Sierra Leone. Without these organizations' support, we would not be where we are today. Their support has been vital to our current success, and we look forward to continue working with them. Next slide.
All right, so to talk about the problem, sickle cell disease is a devastating and prevalent issue across sub-Saharan Africa. Oftentimes in Sierra Leone, this goes undiagnosed due to a lack of understanding of the disease and the inability to test for it. Ultimately, this leads to misdiagnosis. The symptoms are often attributed to malaria or general anemia, and this prevents individuals from receiving the proper management recommendations for the disease. Another important factor of this is that there's a lack of data collection due to the inability to test. The data that we do have really reflects the devastating nature of the disease. For example, 50 to 90% of children with sickle cell disease die before the age of 5. And this is drastically higher than the mortality rate of higher resource countries. Next slide, please.
So our main solution to this is the development of a low-cost point-of-care screening device for the sickle cell disease genotype, which will have a higher specificity than the current method used in hospitals, a sickling test of 60% sensitivity. The device is a lateral flow test, similar to an at-home COVID test or pregnancy test, with lines for control, healthy hemoglobin, and sickled hemoglobin. Our device allows people to test for both the sickle cell disease and sickle cell trait. This design requires a minimum number of steps, adding the sample and then wash with a running buffer to allow complete flow of the sample, meaning that the test is quick and easy to use. While we are still in the optimization phase to make the device context-specific for Sierra Leone, we are working to move forward with manufacturing, field studies, and regulatory approval in the next couple of years. If you could go to the next slide, please. So, as I mentioned, the first strategy that will leverage the symptoms, screening, referral, and diagnosis process is developing and implementing the screening tool that predicts sickle cell disease genotype with more than 95% specificity, tailored to Sierra Leone's context and needs. But how will this look? Imagine a pharmacy board certified device that is present in the market, is widely accessible in both public and private health institutions, and can be used by individuals with minimal training in any setting, including during outreach. Thanks to the low cost of the device, this will be a cheaper and better option for anyone to take the test. Eventually, it will be part of the SOP for newborn screenings, tying this to the malaria vaccine that is starting to be given at 6 months after birth. If you could go to the next slide, please. So while we work on optimizing our device, we are aware that diagnosis is not the whole solution. In order to implement the device into Sierra Leonean community, it is important to also look at the stigma and accessibility to sickle cell disease knowledge in Sierra Leone right now. We traveled to Sierra Leone this past month and established a 4-point plan. This includes implementing a sickle cell screening tool in a point-of-care context in Sierra Leone, facilitating distribution of informational materials to primary healthcare system, capacity building for doctors and nurses through standardized continuing medical education coursework, and standardizing Sierra Leonean care and management of sickle cell disease. We are actively working on all these points to create an overall systemic impact. Next slide, please.
For our education and advocacy efforts, we're working to promote the awareness of sickle cell disease and bolster the educational resources that are available. So as Nicole mentioned, we've been working with various partners over the past several years, and through this, we have identified certain aspects where we can help in material development. So we have partners in McKinney and in various parts of Sierra Leone, and they have advised us in designing posters, flip books, pamphlets. So kind of the process that we go through for this is material development with our partners. Then we bring it to a more government official, such as a district medical officer in the Ministry of Health, to receive verification of the material. Then we work on distribution. So this past summer, we went to an in-charges meeting, which is where there were local PHU nurses, and we distributed a poster to 100 PHUs. And then eventually, we would like to collect data on our materials to have a number of how these materials actually impact the general knowledge and perception of sickle cell disease. So as I said, we've developed some posters, flipbook, pamphlets, and some of our recent accomplishments have been getting our poster and flipbook certified by the Sierra Leone Ministry of Health, and as well as distribution to 100 PHUs. So next slide, please. This is the poster that we distributed this summer. So it is certified by the Sierra Leone Ministry of Health, and what it displays is a general understanding of what sickle cell disease is, common symptoms, how to manage the disease, and this is appropriate for PHU, so local clinics, walls, and this kind of increases the recognition between nurses as well as the people that go to these healthcare clinics, as it's often their first stop when they're not feeling well, to increase that general knowledge and awareness of sickle cell disease. Next slide, please. So many of the advocacy groups that we work with, they go to local secondary schools and present to the teachers, students about sickle cell disease. So something that was requested was a material to bring for teachers to guide them on what to do if a student has sickle cell disease. So this pamphlet addresses common misconceptions, handling a child with sickle cell disease, telling them to allow them to rest if they're tired, and common misconceptions that are important to understand to help encourage a student with sickle cell to continue in school. Next slide. And then our last material is a flip book, and the flip books are often used by nurses on outreach efforts. It provides a visual aid for more rural communities to understand what a device is or what sickle cell is, and There are speaker notes on the back to highlight for the nurses what these pictures are exactly depicting. And throughout this summer, we did receive feedback, and so we were able to optimize these pictures and make sure they're culturally appropriate. All right, next slide, please.
So the majority of doctors and nurses in Sierra Leone lack hands-on experience with sickle cell patients and are unfamiliar with the latest diagnostic and treatment methods. So to address this knowledge deficit, SickleEd is developing a context-specific continuing medical education course to equip healthcare professionals with the training necessary to provide up-to-date and specialized care for sickle cell patients. Next slide, please. So also, there is currently no standardized and unified sickle cell disease care in Sierra Leone. Many neighboring countries dealing with a high rate of sickle cell disease do have standardized policies and procedures in place. So our team has looked to these procedures to develop a standard operating procedure specific to Sierra Leone. Through our collaborative relationships with the Bambali District Health Management Team and the Ministry of Health in Sierra Leone, we will assist in standardizing care for sickle cell disease in Sierra Leone through an SOP and subsequent data collection. Next slide, please. So our project began in 2019, and we have been conducting fieldwork in Sierra Leone every summer for the past 5 years. At the start of our venture, we identified and explored the problem of the lack of sickle cell disease diagnostics and care in Sierra Leone. Next, we learned more about the perceptions of sickle cell disease and the pathways for sickle cell education and care that are currently in place. And now we are developing materials in order to bridge the gap within these systems to create a unified end-to-end system to support sickle cell patients from diagnosis to treatment. Next slide, please.
Through our time at Fieldwork, we have collaborated with various organizations. Most recently, we have been working with Mr. Abdullah Abraham Senko, leader of an advocacy organization in Makeni, Sierra Leone called SHAFS. Here's more information about what SHAFS and Senko does and our work together.
Hello everyone, I am Abdullah Ibrahim Senko. I am talking to you today not only as the founder of Sustainable Humanitarian Advocacy for Sickle Cell, but also as a warrior in the fight against sickle cell disease. My journey both as a victim and as a registered nurse has shaped the very heart of this organization. One out of the several admissions I have suffered of, I developed fluid overload, leading to severe breathing difficulties due to mismanagement. I was also misdiagnosed as a tuberculosis patient and denied hospitalization in another hospital in Sierra Leone. This personal experience, along with witnessing the suffering of others, highlighted the urgent need for better care, understanding, and advocacy for sickle cell patients in Sierra Leone. In Makeni City, there are no diagnostic tools for sickle cell disease, and the lack of government support, data, policy, and medical resources is staggering. Victims face not only physical pain but also societal misconception and discrimination, making it difficult to find employment and live normal life. This is why SHAF was born. Our mission is to eliminate the isolation and discrimination faced by sickle cell warriors while reducing their suffering and early mortality. SHAF has had the honor of collaborating with Sickle, an organization that has significantly supported our work in Sierra Leone. With Sickle's help, we have expanded our network, forging key partnerships that have strengthened our advocacy effort. We hope this support can aid us to collaborate on projects that will make a lasting impact in the lives of those affected by sickle cell disease. Sickle's creation of educational material such as posters for primary health unit, pamphlets for schools, playbooks for outreach, and information pamphlets for parents has been invaluable to our mission. These resources will help us raise awareness and educate communities about sickle cell disease, ultimately leading to better support and care for those affected. Additionally, the development of a diagnostic device by sickle will represent a significant advancement in our advocacy work. These devices will greatly enhance the ability to diagnose and manage sickle cell disease, improving healthcare outcomes in Sierra Leone. Looking to the future, SHAF is committed to continue our collaboration with sickle and any other organization to expand our outreach to help even more people. We envision a future where sickle cell warriors are no longer isolated or discriminated against, and where they have access to the care and support they need to lead fulfilling life. That's why we say sickle cell victims must live, not just survive.
Thank you. Oh, no, I was just gonna say if you could go to the next slide.
I just wanted to acknowledge also thanking Mr. Senko for that video, although he could not be here with us today. His partnership has proven very valuable as we traveled to Sierra Leone this past month, but also as we look towards the future in developing our project. Continuing on that same line, as we do look towards the future, we're currently in the optimization phase. As we have discussed, we are optimizing our device currently and also searching for an outsourced manufacturer so we are able to produce our device on a large scale at a lower cost. And along with that optimization comes the education components that we've been discussing. We hope to continue to work with local organizations like SHAFs to make sure that our educational materials are appropriate for the context that we are using them in, as well as able to actually boost the local understanding of sickle cell disease. Along with this, we are hoping to educate healthcare providers on our device specifically as it becomes available. From there, we hope to implement our device specifically into the standard operating procedures of current newborn care, as well as implement it into different pathways so that those who miss their chance to be diagnosed or screened at birth can still have that opportunity. We also are hoping to have our test covered under the Free Healthcare Initiative in Sierra Leone so that it can be offered at a free or very reduced cost. And then from there on out, our project will be in the maintain stage, and we will hand off our project to our in-country partners to sustain its development while we look at expanding towards other countries. Next slide, please. Thank you so much for listening to our discussion today about our project. If you'd like to scan this QR code and stay connected with our project, our website is right there. And then please don't hesitate to email me with any questions. Thank you.
Thank you very much. So now I'd like to introduce Professor Anne Bachelot. Anne is a full-time professor at the head of the Department of Endocrinology and Reproductive Medicine at, pardon my pronunciation, but Petite Salpêtrière Hospital in Paris. She is the head of the Scientific Council of International Fund Congenital Adrenal Hyperplasia.
Okay, thank you very much, and thank you for giving me the opportunity to take part in this meeting and present the work we do at IFCA. So IFCA is the International Fund for Congenital Adrenal Hyperplasia. It is a foundation that funds clinical and basic research into CAH, and it was created and is managed by patients and relatives of patients suffering from this disease. And it works in close collaboration with the French Patients Association, Association Surrénale, and funds come from donors and the IFM Téléthon. Every year, and I'll come to this point later in my presentation, the Scientific Committee of IFCA selects projects aimed at improving patients' care and treatment. Next slide, please. So there is a partnerships between IFCA, European Society of Pediatric Endocrinology, and European Society of Endocrinology. The object of the partnerships is to join their forces to promote high quality and high impact research on CAH and related developmental, genetic, medical, and psychological issues. To this purpose, IFCA, European Society of Pediatric Endocrinology, and European Society of Endocrinology have decided to create a research grant program specifically aimed on CAH physiopathology. Next slide, please. So call for projects are expected to occur on an annual basis. The total amount dedicated to the program is 250,000 euros that come from IFCA and 100,000 euros that come from AFM for gene therapy projects. So in total, 350,000 euros per year to support CH research projects. Next slide, please. So here you have all the IFCA grant committee. So the projects are selected on based on the advice of the scientific committee. It is a mix of clinicians, scientists, and scientists from pediatric and adult endocrinology. So I am the president of this committee. And here you have the member, Martin Koels, that is a representative of European Society of Pediatric Endocrinology, and Andreas Schedel, that is a researcher in genetic and endocrinology, and he represents the European Society of Endocrinology, and also 4 other members, Eddy Claassen from the Netherlands, she's a pediatric endocrinologist, Anna Lauber-Biazon, also a pediatric endocrinologist from Switzerland, Professor Stefan Borstein from Germany, and Dr. Pierre Val is a research in genetic endocrinology in France, in Clermont-Ferrand. Next slide, please. If you can go to next slide. Thank you. So since the, oops.
Oh, my bad. There we go.
Previous time. Okay, thank you. Since the foundation was set up in 2010, we have received more than 200 projects, 40 of which have been funded for a total budget of 3.7 million euros. The table shows the total funding granted to each project over the years. Next slide. So 21, as you can see, 21 different countries responded to the foundation's call for project. Around 30% of these projects come from France, 15 from the USA, and 10% from Italy, and 10% from Australia. Of course, applications from countries that have not yet applied are welcome. And we select projects that are solid and well designed. And the aim of this foundation is to fund projects that bring together teams from different countries to contribute to joint work, a source of openness and scientific progress in this rare disease. Next slide, please. Oops. So if we look now at the funded project on the 14 calls for project between 2010 and 2024, 24% come from the UK, 21% from France, 19 from Germany, 11 from the Netherlands, 9 from the USA, 6 from Sweden, 2 from Switzerland, 2 from Australia, and 2 from Denmark. But really, every country can apply for foundation. Next slide, please. So IFCA have 2 main objectives. The first is to improve treatment and care management, children health, growth, emergency treatment, fertility, and long-term comorbidities of this disease. And the second is to promote curative approaches, adrenal cell and gene therapy. Next slide, please. If we now look at the research topics funded by the IFCA, we can see that 14% of it concerns men's health, 29% women's health, 24% the treatment of this disease, and 33% of really important gene therapy. Sorry, next slide, please. So I can show you some important results from IFSCA funds. First, improving patients' health. So I have a project on the pregnancy of women that are with a fetus at risk for CAH. Edi Classent is funded for a project on testicular adrenal rest tumor. And Professor Nordenstrom is found for effect and importance of adrenaline insufficiency in patients with CAH. Second, innovative treatment in this disease. Dr. Lee Shine was found for way of androgen decrease, ACTH inhibitors to decrease hyperandrogenism. And Dr. Richard Ross was found for adrenal glucocorticoid replacement in CAH, including intranasal emergency treatment. And finally, we found some new curative strategy for adrenal insufficiency, gene and cellular therapy, and to understand better the process of adrenal cell differentiation for stem cell, to use committed stem cell to drive them to cortisol and aldosterone secreting cells, to use the right vectors to go to clinics with gene therapy. And here are all the persons that have been found for this gene therapy. Next slide. Because genetic and cellular therapy is really one of the most important aspects of our funding. Since 2010, we have funded 11 projects in partnerships with the Téléthon and AFM, and projects from France, from Germany, from UK, from USA. These projects are currently being carried out by Babo, Alexander, and Andreas Schedel in France. Next slide, please. And to illustrate it, the gene therapy, some 10 years ago, IFCA funded a gene project therapy conducted by Dr. Per Domini and Professor Bounière in France. Through this project, researchers have proven the therapeutic effect of a gene vector AAV on human gene with adrenal steroidogenesis gene, hormones, and clinical parameters in mouse model. The vector of gene therapy produced in Nantes was administered systematically. So now this team is currently studying the best way to lead the program towards patients. And in 2021, there is the first CA gene therapy trial that is launched in the US by Adrenas Therapeutic. This clinical trial is based on the preclinical work that we have found some years ago. So if you are interested, you have further detail on our website. Next slide, please. So if you like to find out more about funded projects and how to apply, please visit our website where you find all the resources available. Next slide, please. And we not only found a project, we also have organized an international meeting in 2021 for all funded researchers to present their results. And again, you can go to our website to have more information. And finally, final slide, please. Okay, so I show you how it works. So here is a 2024 call for proposal calendar. So in October, we call for proposal. In January, it's a deadline to submit the letter of intent. In February, the scientific committee is meeting and we pre-select among the candidates. In April, it's a deadline to complete the full project application, and in June, all the teams that have been pre-selected are, there is an audition in Paris by the scientific committee, and then we choose the final project. We make the final selection. So for key dates and all the information, go to our website. And I thank you for your attention.
Thank you very much, Anne. Our next speaker is Dr. Esther Koval. Esther is a dedicated doctor, pediatrician, healthcare advocate, and program manager for Clan Child Health Africa. She works with Clan Child Health Africa and other local organizations to promote programs that support the health and well-being of children, particularly those most vulnerable. Dr. Esther firmly believes that every child deserves access to quality healthcare and opportunities to thrive. Through her advocacy efforts, she strives to create a brighter future for all children.
Thank you, Katie. I think I'm just going to turn off my video so the internet is not interrupted so much. As already mentioned, I'm Dr. Esther, and I'm going to be sharing on how to identify and address barriers to access for care for children with NCDs in Africa in particular. Next. This is just an outline of what my discussion is going to be like, just to define what NCDs are, what's the burden of NCDs, which challenges are children facing in Africa here. And then I'll really go on and talk about what we are doing as Clan Child Health Africa. So in my definition, we know that NCDs really refer to the long-term conditions that they persist over time. They usually require ongoing treatment and care. And these are not usually caused by an acute problem. It's not an acute infection. WHO really looks at 5 main groups. Those are the cancers, the cardiovascular diseases, chronic lung diseases, diabetes, and mental health problems. But we all know very well that when we come to children, these 5 main groups do not exhaustively capture the range of NCDs that children face. And there's really been this growing recognition of neurological genetic issues as NCDs, and point an example at diseases like CAH, epilepsy, sickle cell disease. All these diseases are now being considered as NCDs because they share common characteristics with the 5 main groups. Next. So what does it look like in Africa? We are seeing that NCDs are really becoming a common global health problem, the common health burden for children here in Africa. About 20,000 to 30,000 children are born with sickle cell disease annually in Africa, and most of the burden is in Sub-Saharan Africa. That has really been highlighted on by the team from Lehigh University. But we also see that about 12.7% of children under the age of, more than the age of 5 are diagnosed with neurodevelopmental diseases. Children are born with congenital heart diseases, about 10,000 to 20,000 children annually. And childhood cancers have also really become very, very common in our setting in Uganda. But when we come down to endocrine diseases, renal diseases, gastrointestinal, the data on this information in Africa, in Uganda, in East Africa is really, really limited. And access to care for these children who have NCDs remains a really big challenge. Next. So what are these challenges that I'm talking about in access to care? When you look at access to investigations, most of our children really have limited access to diagnostic tests. 1, because the tests are few. 2, even the few tests that are available are really expensive. And specifically when we come down to the tests for NCDs, CAH, for example, we have so many children attending our clinic in the endocrine clinic. They have ambiguous genitalia, but they've never had an opportunity to be screened for CAH simply because the parents cannot afford to pay for the tests that are required to do these confirmatory tests for CAH. So that really remains one of the very, very big burdens for children. Then when we come down to newborn screening, this for anything really, sickle cell, CAH, congenital hyperthyroidism, these are not routinely done. Well, sickle cell disease screening has been encouraged and pushed. There's some funding for newborn screening for sickle cell, but it's only available in a few of the hospitals in the country. I think I can count 1-2 facilities only. And then even if the government is trying to promote newborn screening through the central laboratory, there are very few facilities that are sending the samples for these diagnostic tests. So there's still a very, very big gap that exists in the newborn screening for these children. When we look at their access to medicine, cost of treatment is high. When we talk about NCDs in particular, most of the drugs for NCDs are not really available on the essential drugs lists. Most of our essential drug lists do not cover these crucial drugs, and yet they are long-term, they are expensive, and the parents usually are not able to afford them. And on top of it not being available in the hospitals, it's also in those facilities where they're able to buy them in the pharmacies, the drugs are really expensive for the parents, and very few are covered on insurance. I know for sure hydroxyurea is covered on probably 2 or 3 of the insurance companies that we have in the country. And yet there are quite a number of parents who are able to afford insurance, but even then they're not able to get the drugs on their insurance cover. So they have to pay out of pocket. And this has really, really made it difficult for patients to stay on medication. So often they miss out on their drugs. Then they only return to facilities when they are worse. So when they have deteriorated, they need emergency care. And this is usually much, much later into the disease. So this is how we end up losing most of our children who have chronic diseases. Next. So the other challenges that exist, of course, health systems challenges. So we have few health facilities that offer specialized care for children with chronic diseases. And even then, most of them are located in the urban centers. And yet a very big population stays in the rural areas of the country. So there's so many children who do not have access to care because they are unable to pay the costs to come to the hospitals. And this is also one of the reasons as to why they only return to the facilities when they are critical, when they are failing. It's because they are unable to get assistance wherever they are close to them. Even our systems are really poorly developed information tracking systems. I will just give an example of the National Referral Hospital where I really have I've worked. We do not have very good systems for tracking children who we receive at the facility. Yes, we record them as they come. We record every visit that they come, but there's usually no follow-up for these children. So if a child is lost to follow-up, no one bothers, because we do not have a system in place to see that we capture all these children. So we only see these children when they come in later and they are sick, they are very sick, or they come back after 5 years, and we do not know what has happened to these children in these 5 years that they've been away. So that is one of the critical things that we have that exist. And this also feeds into the whole essence of we do not know the numbers. We don't know numbers. That's why we are saying our data is limited, because we do not have a system that that keeps track of all children receiving care in the country. So we don't know the number of children who have congenital adrenal hyperplasia. We don't know the true number of children with epilepsy. We don't know the true number of children with sickle cell disease. We have estimates, but we do not know the true number. So these are challenges, because then it's difficult to plan for these children. It's difficult to advocate for to the government to see that they improve on care for these children. So those are some of the very, very big system challenges that we are seeing in our country. And then, of course, big on all these things is stigma, misconceptions about diseases, chronic diseases. In our rural areas, people still believe in a lot of witchcraft. And if a child has a chronic disease, they will say this child is bewitched, or in some incidences, they will blame the mother of the child. So most chronic diseases are usually blamed to the mother. So it's the father is not usually responsible according to society. It's the mother who is responsible for the child's epilepsy. It's the mother who is responsible for this child who has cerebral palsy. So this means that in most incidences, the father leaves the mother. Then the mothers have to struggle to take care of their children on their own, and usually they're unemployed. So they really struggle to see that they take care of their children. And it also brings about like the discrimination from the rest of the community, because they think the mother is the one who is who has ill luck, and that means if they associate with her, the ill luck is going to rub on to all of them. So they try to distance themselves from this particular parent, and this leaves a mother who is alone and struggling with her own child in a very, very sorry state. And in most situations, these parents do not even come to seek care in the hospital because they are afraid of what people will say about their children. So those are the stigma and the misconception in the community is one of the biggest challenges that we see in children who have lived in Africa. And of course, our policies they are lacking, they are limited, and they do not necessarily address the unique needs of the children with NCDs. So their focus is usually on only primary health care and acute illnesses, so diarrhea, polio. That is where the focus is. Little emphasis is put on NCDs. And even our government, our political leaders really do not tend to prioritize NCDs in their discussions. So next, thank you. I'm not going to talk about NCDs across SDGs because we have had a lot of discussion about this. We'll just move on to the next slide. And I want to really share with you what we are doing as Planned Child Health Africa. Planned Child Health Africa, next slide, is an NGO. We really work, our main aim is to see that we maximize the quality of life for children who are living with chronic illnesses in Uganda. We are really a partner of Plan Australia. So most of our strategic pillars really are similar to what Planned Child Health is doing. We really work to address access to medicines and equipment. We focus on education, research, and advocacy, seeing that we improve access to optimal medical management, encourage family support groups, and work to reduce poverty and promote financial independence. We've worked with parents who have children with epilepsy. We are working on a project in CAH. We've worked on a video for sickle cell disease, and we are also working on some training for parents of children with epilepsy. Next. So in these pictures, the first you'll see, those are children who are living with epilepsy. We had a celebration of Purple Day. We surprised the parents. This is a hospital. This is the National Referral Hospital where we were. And it was a clinic day. They'd come for their normal reviews, and we just decided, let's have this day with these parents and just talk about epilepsy. And this is the day that brought these parents together, but also it gave us a chance to start a family support group for parents of these children who have epilepsy. So we have a WhatsApp group for parents, and we engage them. They share with us their fears, they share with us what they think, they share with other parents and encourage them. So that is an active group that we have with parents with epilepsy. Significantly, we've also worked on an epilepsy rights flyer, which we did share with the parents, and they were happy to receive it. And we've done a bit of advocacy and talks on CAH. We've worked with parents of children with nodding syndrome. That's the group that you're seeing down there, the parents. We also shared about neonatal screening. On 28th of June, we had a flyer go around on neonatal screening. And the last that you see down is the celebration we had on the International Epilepsy Day. It's a celebration. It was a launch of a day when we had the launch of epilepsy surgery in Uganda. It's being done by one of the surgical hospitals, but working in collaboration with the pediatricians and the neurophysicians in Uganda. And it was a very successful day that we participated in. Then lastly, I'm going to talk about the research. So the research that we are doing, next slide. We are doing a research on the CAH in the CAH community. Next. We're going to be doing a research in the CAH community. This is going to be this has been funded by a grant that we got from Mates for Kids. Thank you. And the purpose of this research is really to do strengthening of early childhood diagnosis for health workers and to build their capacity for them to be able to do newborn screening for children with CAH. The reason as to why we chose to work with the health workers is because in Uganda, CAH is one of those diseases that very few people know about. And it's not just the community, but even our health workers themselves do not know about CAH. And so this was a very big gap. And we thought that if we start with the health workers, then we can improve on screening for these children with CAH. Then we can improve on the number of children with CAH who actually reach the endocrinologists. And then it will be much easier for us when we have numbers. Then we can advocate for treatment. We can advocate for medication, investigations to be available for these children. So the purpose of this this research is to really strengthen the capacity of health workers in identifying, investigating, managing, and referring the newborns who have CAH, who have possible CAH, to the pediatric endocrinologists for continuity of care. We are focusing really on education research, optical medical management, because we are training the health workers and because we are doing newborn screening. So the main objectives for this study are: one, we have to carry out a knowledge, attitudes, and practices assessment among the health workers to see where they are with the knowledge. But also, after we have done the knowledge assessment and the practices assessment, we want to train these health workers in visual screening. So because the cost of doing the heel prick is not very affordable for us right now, we thought at least we can start with visual screening. So specifically being able to identify children who have ambiguous genitalia, and those children are referred for further care. Being able to look at newborns who are presenting to the hospital, especially the baby boys. What first neonatal period represent with dehydration. We want our health workers to have a high index of suspicion for such children and be able to refer them for further screening, or at least be able to conduct the basic tests, electrolyte tests for these children, and then refer them for care. Because we are losing very many boys, we do not know, but it's possible that we are losing very many boys to CAH. So we want to see that we improve on the quality of life for those children by doing early diagnosis in them. And then the third thing that we are doing for this study is we want to conduct health needs assessment survey among the health workers. So we see what do they need for them to be able to work on these children well. And lastly, we want to be able to set up a referral pathway for the children with CAH from diagnosis all the way up to the endocrinologists, so including follow-up and making sure that they are not lost between diagnosis and referral. So those are the main objectives of the study. It's a pilot study. We're going to do it at one of the national referral hospitals that really works with children and mothers. And it's going to be both qualitative and quantitative. We are looking at targeting at least 250 health workers, and these will include the doctors, the nurses, midwives, and even laboratory attendants, so they understand the tests that are done. And it's a 12-month period study, and some of the activities I know I've already mentioned. So this is really just a pilot, and it's a start. But we hope that we can be able to do more after this study. And I know, Anne, I am going to be looking out for the next opportunity so that we can apply for more grants to be able to do better with the CAH community. Last page is really a thank you to all of you for joining in and for being part of this discussion. Thank you. Over to you, Katie.
Thank you so much. So now I'm going to introduce Dr. Francisca Grob. She unfortunately couldn't be here with us today, but she sent us a recorded presentation. She is a dedicated pediatric endocrinologist with a deep passion for neonatal screening of congenital hypothyroidism. She works at the Pontificia Universidad Católica in Santiago, where she serves as an assistant professor. So I'm going to go through her slides, and she has videos attached, so we'll all be able to listen in.
Hello, everyone. Thank you so much for the invitation to this interesting meeting. I am Francisca Grob. I am an assistant professor at the Pontificia Universidad Católica de Chile, and today I'm going to talk to you about newborn screening for congenital hypothyroidism, insights from the Latin American experience. So I'm going to talk about generalities about congenital hypothyroidism, how screening in Latin America has developed, takeaways from this experience, and possible application to low and middle income countries. So newborn screening for congenital hypothyroidism is marked by last year's 60th anniversary of the publication of the landmark paper by Guthrie and Ceci describing a simple method for the neonatal detection of phenylketonuria on dried blood spots collected on filter paper, often referred to as Guthrie cards, for the pre-symptomatic detection of congenital hypothyroidism. Overall, newborn screening has led to earlier diagnosis and improved cognitive outcomes in children. However, there has been a learning curve which has taken years to get to current outcomes. Because newborn screening led to cognitive outcomes within the normal range in children with PKU and CH, it has progressively implemented as a public health program in all high-income countries. While some high-income countries, such as the USA, now screen newborns for up to 50 different conditions, it is sobering that only 30% of world newborns have access to any newborn screening at all. Before newborn screening diagnosis for CH, it occurred at 9 months of age on average, with a mean IQ of 86 and 20% of individuals having an IQ below 70. After newborn screening was implemented, diagnoses were made as early as less than half a month of age. Mean IQs rose to 105, and instances of IQ below 70 dropped to none. Treatment dosages significantly increased from 6 to 10 to 15 micrograms per kilo per day of thyroxine. The incidence of CH became more frequently detected, from 1 in 600 and 500 births to 1 in 2,500 lately. So the primary objectives of newborn screening includes the early detection and prevention of serious health issues in newborns. For conditions such as salt wasting 21-hydroxylase deficiency, The goal is to prevent neonatal death by early intervention. In the case of sickle cell disease, newborn screening aims to reduce infant mortality rates and decrease the overall morbidity associated with the condition. Lastly, for hypothyroidism, the screening endeavors to avert potential lifetime intellectual disability through timely diagnosis and treatment. These efforts are crucial in improving the quality of life and health outcomes for affected children. So congenital hypothyroidism poses a significant public health challenge due to its impact on child neurodevelopment. Early detection through neonatal screening is essential for preventing intellectual disability and other long-term consequences. So for the American Academy of Pediatrics, the priority of newborn screening programs is the detection of infants with moderate to severe primary hypothyroidism, which can lead to intellectual disability if not detected. Secondary priorities include the detection of infants with mild primary hypothyroidism, late onset primary hypothyroidism, or delayed TSH elevation, or central hypothyroidism. So once the prevention of iodine deficiency at the population level has been achieved, newborn screening for sporadic CH, which has an estimated prevalence of 1 in 2,000 to 1 in 4,000 births, should be implemented. Prevalence depends mostly on the TSH cutoff, but also on other variables such as the ethnicity, gestational age, and associated morbidities. Mild cases of congenital hypothyroidism have been increasingly detected in many high-income countries, one of the main reasons being the decrease in the TSH cutoff, leading to an estimated birth prevalence of up to 1,000 in some countries, compared to 1 in 6,700 before the establishment of newborn screening programs. Whether there is any benefit in treating these less severely affected children remains to be established. So, in low and middle income countries, the focus has been historically on detecting and treating communicable diseases. For non-communicable diseases, the focus of newborn screening programs should be on the most prevalent and treatable conditions in the country considered. In many low and middle income countries, this includes sickle cell disease. Latin America is a region consisting of 12 countries. Mexico in North America, some other countries in Central America, Cuba, Haiti, and the Dominican Republic in the Caribbean, Argentina, Bolivia, Brazil, Colombia, Chile, Ecuador, Paraguay, Peru, Uruguay, and Venezuela in South America. These countries can be characterized as presenting a great diversity in terms of geographic area, as well as in terms of demographics, ethnicity, economies, and social and healthcare systems, with the language being one of the most important shared characteristics, since all of them, except Brazil and Haiti, are Spanish-speaking countries. Unfortunately, the implementation of newborn screening programs in low and middle income countries in Latin America have been delayed when compared to high and income countries, and many children within the region don't have currently access to any newborn screening programs. So according to the World Bank's classification of countries by income level, only Chile, Panama, and Uruguay are classified in the high-income group, representing 15% of the region countries. On the other end of this classification, Haiti is the only country included in the low-income group, while the remaining 16 countries, that is 80% of the total of the region, are classified in the upper and lower middle-income countries. And when a revision of the history and evolution of the newborn screening activities in Latin America is made, it can be seen that the previously mentioned diversity also applies to newborn screening. Such diversity can be highlighted when analyzing different newborn screening parameters like the year of implementation as organized programs, the modality of organization, the panel of diseases screened for, the available technologies for testing, the coverage reached, the legislation in force, and the degree of development and success reached. Taking into account such parameters, and despite that in practice a continuous spectrum of possibilities is found, the Latin American countries can currently be classified into 5 groups. First of all, we have the countries with optimal fulfillment of newborn screening programs. Then we have a massive group of countries going through a phase of growth and newborn screening expansion. Then we have a group of countries whose newborn screening activities were launched and not very well implemented, and other countries at the bottom with nearly no newborn screening available. This image depicts the Human Development Index values by country, grouping from 1990 to 2017. At the beginning of the 1990s, when Chile initiated his neonatal screening program for CH, the country was positioned within the same Human Development Index than currently correspond to other countries classified as low and middle income countries. This demonstrates that despite facing significant challenges, it is possible to organize and implement a complex program of this nature, achieving substantial progress over time. Chile, a country located in western South America, it is the southernmost country in the world and the closest to Antarctica. Within a big area and a population of 19 million inhabitants, Chile shared borders with many countries. The Chilean program prospectively collects data on children diagnosed with CH from the public health system, representing 75% of the Chilean population. 2 screening centers receive samples from 16 regions and collect data only related to the diagnosis of CH. Initiated in 1992, it covers up to 99% of the target population and collects samples from infants after the first 40 hours of life. It has a legislation in place since the beginning of the program, and it has national funding. It has 2 national laboratory reference, plus the private laboratories that receive the samples of 20 to 25% of the Chilean population. And we use TSH whole blood for the diagnosis of CH. We have around 150,000 births per year with high coverage and low recall rate, and we have some post-analytical problems in the follow-up of the program. After our Latin American meeting in 2021, we organized our challenges in this information with some challenges that we have been facing in the pre-analytical, analytical, and post-analytical phase in many of the Latin American countries. First of all, we realized that not every country has protocols and guidelines used to interpret the results and define the actions. Not all public is enough educated to accept neonatal screening, and many countries have a fragmented healthcare system that can complicate coordination. The number of births is highly variable, and we have lots of rural population in many of the Latin American countries. The analytical phase is also critical because centralization of sample processing is not always very easy, and the need of daily sample processing is also a challenge because not every weekend, for instance, people are able to work. In the post-analytical phase, the communication between diagnostic and follow-up centers is essential. Patient registry is where mostly everyone fails, and the coverage of the medication is not always easy. Finally, allied health professional participation is not always available to support patients and families. So we came up with a possible approach. Like BCG vaccination programs are widespread in low and middle income countries, with most children being immunized in the first months of life. One of the reasons why newborn screening lags behind in immunizations may be that the collection of the Q3 cards, which has to be sent to central laboratories, is not feasible in many low and middle income countries. Point-of-care testing, or POCT, or called near-patient testing or bedside testing, is defined as a medical diagnostic testing at or near the point of care of the patient, near the bed of the patient or where the patient is being cared for. And this contrasts with the historical pattern in which testing was wholly or mostly confined to the medical laboratory, which entailed sending of specimens away from the point of care of the patient and then waiting hours over days to learn the results, during which time care must continue without the desired information. So collection of a blood sample from the baby by a community health worker trained in POCT at home or at the infant's earliest visit for immunization may be the way of the future for newborn screening in low and middle income countries. POCT for sickle cell disease, for instance, is available and has been tested. However, this technology is still being developed for congenital hypothyroidism. In this context, since 10 to 40% of the population of Africa is affected by sickle cell disease, a study was organized to test the feasibility of implementing a screening program for SCD using POCT devices within existing immunization programs in primary healthcare settings in Africa. Therefore, they screened children for sickle cell disease during their first well-child visit to receive their initial vaccinations. They utilized available resources from their primary care system, incorporating the POCT. Over a period of 2 years, they assessed children under 9 months old, diagnosing 51 children with the condition and following up with almost 90% of them over a period of 9 months. So evidence already exists of the use of POCT for determining TSH concentrations. This study demonstrated high sensitivity and specificity in detecting TSH using POCT compared to a reference method, and no significant differences were observed between the TSH values provided by fine care, intravenous capillary, blood, or serum versus the reference method. On the other hand, high sensitivity and specificity were demonstrated for diagnosing thyroid disorders with a good correlation. This other Italian study compared another POCT with a reference method, also obtaining excellent correlation between both techniques, meaning the POCT and the reference method. However, newborn screening that's not simple involves testing, but it is a process that involves 6 stages and is generally organized and performed by public healthcare systems with the resources and authority to carry out universal screening. Each element of the screening process required resources, training, standardized and accredited procedures, and quality controls. Patient advocacy ought to be positioned at the core of this screening system. Screening programs have been progressively expanding, often driven by family organizations. However, caution must be exercised regarding partnerships formed between researchers, pharmaceutical industry, and patients. Today, commercial interests, often informally allied with advocacy groups, are at the forefront of efforts to expanding screening. So, newborn screening for sickle cell disease and CH are essential in low and middle income countries to improve the health outcomes of those affected. Linking newborn screening to early immunization programs in low and middle income countries could have several benefits. First, it would allow for the efficient use of resources and infrastructure. Newborn screening for both sickle cell disease and congenital hypothyroidism could be done using the same blood sample, reducing the need for additional testing and saving time and money. Also, linking newborn screening to early immunizations should increase newborn screening coverage. However, we think that POCT methods for sickle cell disease and congenital hypothyroidism provide an initial step to increase awareness of both conditions and to acknowledge the necessity for long-term care of affected children. Challenges to implementing newborn screening programs, including the lack of resources and awareness, must be addressed. Future research and collaborations between high-income countries and low-income countries could help to improve the implementation of newborn screening for SCD and CH in low and middle-income countries and reduce the burden of these conditions globally. I would like to acknowledge everyone who helped me with this presentation and who's been mentoring me, like Dr. Gibbon Bleed, Anna Chiesa, and the people working in the Chilean Laboratory for Newborn.
Okay, so now I'd like to reintroduce Kate to discuss the Mates for Kid community development grants and other upcoming events.
Thanks very much, Katie, and huge thanks to Francisca for that terrific presentation. So many synergies and connections between the presenters today. We're nearly coming to an end, but I just wanted to share a couple of things. Firstly, just acknowledging the fantastic grant recipients that we've had with the Mates for Kids grants. CLAN is the Australian NGO, is in our 20th year this year. We were founded in 2004, and in our 20th year, and as we approach 2030 and trying to reduce preventable mortality by 30% by 2030 in line with SDG 3.4, it made sense we started looking at how we might achieve that, and we worked out we'd need to drive change in at least 40 different countries. And so we're aiming to give 40 grants by 2030 to drive change. The grants are for action in lower income countries only. Our first grant recipients, Colombia and Sri Lanka, have already done great things. And I mentioned I shared a photo of the CH Club meeting in March this year in Colombia. Sri Lanka have been developing resources, holding first ever CH Club meetings, doing some terrific stuff there. Our Grant 2 recipients, we heard from Dr. Esther today, the great work that they're doing in Uganda. There's a newborn screening pilot trying innovative use of filter paper in the Solomon Islands that's underway. And the team in Kenya is doing some education. Next slides. Thanks, Katie. With Grant 3, we will have 2 recipients. One we'll announce a little bit later, but I just wanted to mention today the team from Nigeria's project as an example of one of the grants. They'll be looking at integrated training and support for identification and management of CAH. So their project will be aimed at determining the role of integrated training and support for healthcare providers, parents and caregivers in the identification and management of congenital adrenal hyperplasia. Some similarities to the work that the team in Uganda decided to undertake, which is interesting. So they're very interested in building the knowledge of healthcare providers in the identification and management of CAH, understanding the impact of the training that they'll be giving, but also understanding the perspectives of parents and caregivers, and the impact that club meetings can have on people living with CAH. So we're really excited about that. We'll be talking more about another grant recipient as well that we're working on as well to finalise their proposal. But a huge thanks to the local people driving local change. Really, really proud of what they're doing. The Mates for Kids grants are very small. We acknowledge that they're only 1,000 Australian dollars, but it's exciting that Dr. Esther's already been inspired by the presentation by IFCA today, and we hope that people can transition in to other grant opportunities in the future. Next slide, thanks, Katie. Also wanted to let everybody know about an upcoming event that might be of interest to some or all of you, is the GPED, Global Pediatric Endocrinology and Diabetes, their first annual meeting. It'll be held in October and November. It'll be I think it's hybrid. I think there are some people going to be in person, but certainly virtual participation is possible. Very affordable for people in low-income countries, registration fee of $15. And there's a QR code there, and more information you can Google GPED conference and it comes up quite readily. Just with 3 minutes to go, I just wanted to reflect on some of the things that we heard today, and I think we heard some amazing numbers. Professor Aman was talking about CAH in the pilot screening so far. They've diagnosed 9 children out of 66,737,000 screened. And when you expand that out to 4.6 million children being born a day, if you had 100% coverage, I've just been doing back of the envelope scribblings, that's about 620 children a year born with CAH in Indonesia. And they're children that would be dying or diagnosed late and experiencing quite significant complications if it wasn't for the amazing work that they're doing to try and diagnose more children. Likewise, with congenital hypothyroidism, really striking stories and photos from Aman and Francisca, IQ of less than 70 for those that aren't diagnosed early. And just again, looking at the numbers that Aman presented, you're looking at about well over 1,000 children that would have really severe developmental delay if it wasn't for newborn screening. The numbers that Dr. Esther and the sickle team gave around sickle cell disease, 200 to 300,000 children born each year with sickle cell, and the team at Lehigh talking about 50 to 90% mortality for children under the age of 5 years. So I just mentioned these numbers because it's really important in the context of the SDGs, even just the projects that we're working on here. We have the opportunity to make a really big impact on the lives of a lot of different children. I want to trying to think about some key messages that we've heard. We heard about the importance of access to medicines, of community development and newborn screening, and those messages came out. But I think we also heard today about the importance of hearing the voices of people living with NCDs, and just really want to acknowledge Shafs and that video that you guys got from Sierra Leone. I thought that was really powerful. Thank you. And the power of young people. Really want to acknowledge Katie, who's helped coordinate this session, but the whole team from Lehigh. And there's lots of youth volunteers helping the Clan Child Health Africa team. I just think that young people are really inspirational, and you guys are doing a lot to help us achieve the SDGs by 2030. And innovation, point of care testing, embracing that, but also integration. And Dr. Francisca talked about integrating it with immunisation, but we're also now sort of thinking about integrating hypothyroidism and sickle cell disease in point of care testing. What does that look like? So lots of interesting things have come out of this today. And I just sort of, the other thing is local champions and locally driven solutions and approaches. What Chile's achieved, what Indonesia's achieved in newborn screening is really exciting. So I just really wanted to thank everybody for their fantastic contributions to the discussions and the topic that we had today, bridging science and health equity, reducing preventable mortality associated with childhood NCDs. I think we just really covered a lot of ground today, and I really want to thank all of our speakers for everything that they've contributed. Thank you, Katie, again for your work, and I'll just hand over to you to close up for us.
Yeah, so that concludes our event. Thank you to everyone who's been involved. Your support is very valuable. We're very grateful for everyone's support and allowing us to do the work that we do. And we hope to stay in contact with everyone. We'll have this recording posted on the Mates for Kid website and the Clan website soon, and we'll have a report coming out soon. So thank you everyone for being here and for contributing.
Thank you very much.
Thanks, everyone. Bye.